Right now, and up to a quarter of the people listening to this, the optic nerve, the actual vital biological cable powering your vision, is dangling completely exposed.
Yeah, it really is.
Just floating there in the dark, empty space of your sinus cavity. I mean, there is literally no bone protecting it in those cases.
Just a very thin membrane.
Right, and sheer luck keeping it safe from the outside world. Today, we're taking a deep dive into the hidden, highly pressurized geography of the human face and skull.
It's a really intense topic.
It really is. We're guided by specialized medical literature looking at complications in head and neck surgery. And our mission today is to understand the absolute tightrope that surgeons walk when they operate on the sinuses, and why manipulating just one tiny piece of this ecosystem can cause your body to react in these completely unexpected cascading ways. So, okay, let's unpack this.
Let's do it.
Because mapping out these clinical realities is a journey that, frankly, fundamentally changes how you view your own anatomy.
It does. It really reveals that the head is not, a solid permanent sculpture.
Right.
It is an intricate, highly variable machine. And when we look at surgical complications, not just as medical errors, but as biological responses, we get this amazing masterclass in the engineering constraints of the human skull.
Wow.
By examining what happens when things go wrong, we actually start to understand the underlying mechanics. You see why this anatomy requires such a high-stakes puzzle of pressure, tension, and structural integrity.
And that structural puzzle, it starts right at the surface, right before any instruments even breach the deeper skull.
Exactly.
If we look at the medial canthal area, which is the delicate skin on the bridge of the nose right between your eyes, we see how a millimeter deep intervention carries massive implications.
It's incredibly delicate there.
Yeah, and surgeons actually avoid using normal stitches or clips in this specific area because the skin is so uniquely thin. Like traditional closures would just create thick, bulky scarring.
Right, so to bypass that scarring, surgeons rely on something called bipolar cautery.
Which is gurney.
Essentially, yes. Instead of physically tying the tissue together, they use high-frequency electrical currents to basically weld the blood vessel shut.
Wow.
It's this precise burn that manages the bleeding without leaving, the microscopic bulk of a suture thread behind.
That's fascinating.
And when an incision is absolutely necessary, it's usually cut in a zigzag pattern.
Not a straight line.
No, because a straight line across the bridge of the nose would heal into this tight, visible band that actually pulls the surrounding tissue.
Oh, I see.
Yeah, a zigzag disperses that mechanical tension, which allows the scar to, camouflage itself within the natural tension lines of your face.
But, preserving the surface aesthetic doesn't really matter if the underlying foundation shifts.
Exactly.
And that brings up the bone membrane
Yeah.
and this physiological chain reaction that feels almost mechanical. Because under the skin, you have the periosteum, which is this tough, fibrous membrane that tightly wraps the bone. And the text notes that if a surgeon elevates this membrane and doesn't anchor it back to its exact original position, the patient can actually develop hypertelorism.
Yes, and the mechanics of hypertelorism perfectly illustrate the continuous tension your face is under right now.
Yeah.
The periosteum in that specific spot acts as the anchor point for the medial canthal ligament.
The tether.
Right, it's a biological tether, literally pulling the inner corners of your eyes inward to keep them horizontally aligned.
Okay.
So if that periosteal anchor is disrupted and it fails to heal securely to the bone, that inward tension is just lost.
And so what happens?
The outward pull of the surrounding facial muscles takes over, and the eyes will physically begin to drift apart and round out.
Wait, literally drift apart. That is terrifying.
It is.
And the mechanical fix for that drift requires some heavy carpentry. Surgeons actually have to drill a hole directly into the solid nasal bone, thread a permanent suture through that hole, and physically tie the eye's tendon back to the bone to crank everything back into the center.
That's right.
And this is all happening millimeters away from the lacrimal apparatus.
Right, the plumbing system for your tears, which is just another microscopic vulnerability in this area.
Yeah.
The lacrimal system relies on these tiny fragile ducts to siphon tears away from the eye and drain them into the nasal cavity.
So if a surgeon slips,
If an instrument strays just a fraction of a millimeter while they're lifting the soft tissue, they can crush or sever that plumbing completely.
Wow.
The immediate result is epiphora. It's a condition where tears just have nowhere to drain.
so they just spill out.
Yeah, continuously spilling down the patient's face until temporary or permanent plastic stents can be installed to artificially reopen that pathway.
Man. There's another detail from the deep dive sources that feels more like a thriller than a medical text to me.
Oh, the ethmoid mucocele.
Yes. It involves this tiny microscopic mistake turning into a literal biological time bomb.
It's wild.
During these external procedures near the eyes, if a surgeon accidentally pushes even a microscopic fragment of mucosal tissue under the skin or bone during closure, that tissue doesn't just die off and absorb into the body.
No, it doesn't. Mucosal cells are remarkably resilient, and they follow a very strict biological programming, which is to secrete mucus.
Right.
So if a fragment of that tissue is sealed under the skin without any natural drainage pathway, it just does its job.
It just keeps working.
Yep, it slowly, continuously produces mucus,
Yeah.
day after day, year after year, and it slowly expands into a pressurized cyst.
And because of this resilience, there are documented cases where an ethmoid mucocele emerges 7 years after the initial surgery. 7 years. It's like leaving a tiny dormant seed under a newly paved driveway.
That's a great
It
analogy.
just sits there in the dark for almost a decade, totally unnoticed.
Yeah.
And then the patient catches a common cold. That upper respiratory infection triggers an inflammatory response. And suddenly, this dormant, pressurized mass swells up and breaks through the tissue right on the old incision line.
It's a really striking reminder that tissues retain their function regardless of their location.
Yeah.
And, moving physically upward from that delicate space between the eyes, the surgical landscape expands into a much larger structural challenge.
The forehead.
Exactly, frontal sinus.
Right. And we naturally assume modern medicine just uses an endoscope for everything now. A camera set up the nose.
Which is very common, yes.
But external approaches, which mean literally cutting through the face or scalp, are still entirely necessary. Because an endoscope is essentially a straight, rigid rod.
Right.
It can't bend around tight corners to reach far lateral extensions of the sinus. And it also struggles with these massive Kuhn type 3 or type 4 cells.
Yeah, those are aggressive.
Right. These intricate honeycombs of air pockets that push incredibly high up to the forehead bone.
So to gain wide access to those complex areas, or, to repair fractures and spinal fluid leaks in the bony basin that holds the front lobes of your brain.
The anterior cranial fossa.
Exactly. Surgeons have to open the roof. And the access routes require this really difficult calculation of long-term damage.
Right.
They might use a gull-wing incision across the eyebrows, a direct brow incision, or a bicoronal incision.
Which means a cut straight across the top of the scalp, right from ear to ear.
Yeah, and the trade-off between the visible scar and unseen nerve damage is brutal,
Because cutting lower down, near the eyebrows, leaves this unavoidable, highly visible scar right on the front of the face.
which many patients understandably want to avoid.
Sure. So to avoid that, they can cut much higher up, hiding the incision behind the hairline. But doing so guarantees they will sever the supraorbital and supratrochlear nerves.
Right, the main sensory cables running up the forehead to supply feeling to the scalp. And the loss of that sensation translates into a highly specific, everyday hazard.
This part blew my mind.
Yeah, because the scalp becomes profoundly hyposthetic, which means completely numb to temperature, and pain patients lose their primary warning system.
Wow.
So for anyone who blow dries their hair, this numbness becomes a serious danger.
Right, severely.
Yeah, they physically cannot feel the heat radiating from the blow dryer, so they can easily give themselves severe, localized third-degree burns simply by doing their morning routine,
That is insane.
entirely unaware that their tissue is cooking.
Okay, wait, I have to challenge the logic on that.
Okay.
If slicing those nerves causes such a massive portion of the head to go completely numb, opening the patient up to accidental third-degree burns for the rest of their life, why would a surgeon ever authorize a true vertex bicoronal incision across the top of the head?
It's a fair question.
Why not just deal with a visible scar on the brow?
Well, it comes down to the profound psychosocial impact of facial scarring. For a lot of patients, a visible, permanent scar straight across the face alters their identity and their daily interactions in ways they just cannot accept.
Okay, I can see that.
The true vertex incision hides that trauma in the hair. And furthermore, surgical technique has evolved to really mitigate the cosmetic risks of the scalp cut.
How so?
A skilled surgeon will bevel the incision, so they angle the scalpel blade to cut perfectly parallel to the patient's hair follicles rather than slicing straight down.
Oh, wow.
Yeah, by avoiding the destruction of the hair roots, they prevent permanent alopecia, so hair grows back through the scar to completely hide it.
So it's a calculated sacrifice.
Exactly, internal sensory loss in exchange for preserving outward identity.
It's an incredible compromise.
It is.
But, once the scalp is peeled back, the challenge shifts from managing skin and nerves to breaching the structural wall of the forehead itself.
Right.
The reality of gaining access to the brain's front border sounds a lot like heavy industrial labor to me.
It really does.
Like, if a surgeon needs to locate a blocked drainage pathway, they might perform a trephination.
Yeah, trephination is a very old concept, but it has modern applications. The surgeon physically drills a small hole straight through the outer bone of the forehead.
Just right through the bone.
Right, and through that hole, they pump saline mixed with diluted fluorescein dye. They're basically attempting to see where the fluid naturally drains out into the nasal cavity.
Which they're monitoring from below with an endoscope.
Exactly.
But the margin for error during that flush is terrifying.
Oh, absolutely.
Because the frontal sinus shares its back wall directly with the brain cavity. If the surgeon is pumping dye into the forehead and doesn't see it draining out into the nose, they have to stop immediately.
Right away.
Because the pressure means the fluid is finding another exit. And there's a very real risk they are pumping saline dye backward directly into the intracranial cavity and right over the brain.
Which is exactly why maintaining those structural boundaries is paramount. In the early days of sinus surgery, severe infections were managed with blunt force anatomical changes.
Like the Riedel operation.
Yes. That involved entirely removing the front wall and floor of the frontal sinus and simply leaving it out.
Wait, leaving it out?
Yeah. The logic was to let the soft tissue of the forehead naturally collapse inward, pressing tightly against the back wall of the sinus to permanently obliterate the infected airspace.
Which effectively cured the infection by leaving the patient with a completely disfiguring, caved-in forehead.
Unfortunately, yes. So eventually, surgeons tried the Killian modification.
Right.
That involved leaving just a thin rim of bone to maintain the shape of the eyebrow ridge.
But that just created blind pockets behind the bone where new cysts and infections could hide and fester.
Exactly. What's fascinating here is how modern surgical technique evolved to solve this dual requirement.
The functional drainage combined with structural integrity.
Right. And that evolution culminated in the osteoplastic flap.
The mechanics of the osteoplastic flap are just wild.
They really are.
Instead of just cutting a chunk of bone away and discarding it, they trace the outline of the sinus, cut the bone like a trapdoor, and fold it forward. But they leave the bone attached to the periosteum, that living membrane we talked about earlier.
Yes, the biological hinge.
Right, they keep the biological hinge intact so the blood supply continues to feed the bone. They do the surgery inside the cavity, then fold the living bone plate back up like a puzzle piece so it doesn't suffer from necrosis and die.
And that vascular connection is non-negotiable for the bone's survival.
Right.
Once the sinus is laid open, the surgeon must completely eradicate the space to prevent future infections.
Which means drilling.
Meticulously, mechanically burring away every single microscopic cell of the mucosa using a surgical drill. And they have to be especially careful around the foramina of Brichette.
What are those?
They're these tiny, naturally occurring bony canals in the skull that have small veins. They act like microscopic pits.
Oh, I see.
So if the drill misses even a single cluster of mucosal cells hiding down inside one of those venous canals, that trapped tissue will slowly secrete mucus, eventually breeding a massive mucus cell pressing directly against the brain cavity.
And if the bone plate happens to fracture to pieces while they're initially cutting that trapdoor, they have to rebuild the skull using titanium mesh.
Right, manhole cover.
It's exactly like extreme home renovation.
Yeah.
Cutting an access panel in drywall, checking the pipes with fluorescent dye, patching the structural holes with metal, except the drywall is your skull, and the pipes are millimeters away from your frontal lobe.
The mechanical parallels are really striking, but as heavily fortified as the forehead is, the surgical landscape becomes exponentially more precarious as we travel to the deepest, most central hollow space in the skull.
The sphenoid sinus.
Exactly.
Here's where the architectural design gets really interesting. To reach the sphenoid sinus, you are navigating to the exact center of the head.
Yes.
And it's surrounded by the most critical biological infrastructure in the body. You have the internal carotid arteries forcefully pumping blood straight to the brain, optic nerves, the cavernous sinuses, and multiple cranial nerves that control every tiny movement of your eyes.
It is an incredibly crowded intersection, and the primary danger stems from a common anatomical failure known as dehiscence.
Right.
Dehiscence occurs when the thin layer of bone that is supposed to separate the empty air cavity of the sinus from those vital structures simply fails to form during human development.
And the statistics on dehiscence are staggering.
They really are.
The text notes the internal carotid artery is left completely exposed, floating without any bony protection in the sinus cavity in up to 14% of people.
Yeah.
And the optic nerve is left dangling completely naked in up to a quarter of the population.
It's crazy to think about. Millions of people are walking around with the primary blood supply to their brain and the wiring for their vision separated from the outside air by nothing more than a microscopic layer of mucous membrane.
So if there are literal exposed arteries and optic nerves hanging in the dark,
Yeah.
and we already know that cutting through the face creates this terrible narrow tunnel of visibility,
Yeah.
how on earth is it physically possible to operate in that space without blinding someone or triggering a massive hemorrhage?
The sheer danger of that anatomy actually forced a total paradigm shift in modern skull-based surgery.
Oh, really?
Yeah. External approaches, which forced surgeons to look down a long, dark corridor where they couldn't see around corners, have largely been abandoned for complex sphenoid work.
So what's the solution?
The development of the four-handed advanced endoscopic technique. An otolaryngologist and a neurosurgeon work together simultaneously, threading their instruments exclusively through the patient's nostrils.
Oh, wow.
Yeah, two hands drive the high-definition cameras and lighting, while two hands perform the delicate microsurgery. It physically brings the surgeon's eyes right up to those floating, vulnerable structures.
But even with high-definition cameras, the space is incredibly tight and instruments can slip.
Absolutely.
If that exposed carotid artery gets nicked, tying off the bleeding vessel is nearly impossible because there just isn't enough room to maneuver standard surgical cuts.
Yes.
But this is where biological ingenuity takes over.
Yeah.
The text highlights researchers Valentine and Wormald, who used a sheet model to engineer a brilliant fix for carotid blowouts.
Yes, the crushed muscle patch.
Exactly. They discovered that if a surgeon takes a small piece of the patient's own muscle, physically crushes it, and slaps it directly over the hole in the bleeding artery, it acts as a powerful hemostatic patch.
And the mechanism behind that crushed muscle patch is just brilliant biology.
How does it work?
When muscle tissue is severely crushed, it immediately releases a massive amount of tissue factor, also known as thromboplastin.
Okay.
This chemical aggressively triggers the body's clotting cascade right at the exact site of contact.
So it seals the hole.
Yes, it seals the hole in the arterial wall from the outside without creating a massive floating blood clot inside the artery that can travel up to the brain and cause a stroke.
Which is amazing because the alternative, the old school method of just aggressively stuffing the sinus cavity full of gauze and surgical packing to apply blunt pressure to the bleed is devastating.
Truly devastating.
Because the sphenoid sinus sits right next to the cavernous sinus. If you forcefully pack the area, that mechanical pressure transmits directly through the thin bone.
Yeah.
The pressure alone compresses the optic nerve, causing instant blindness, or crushes the cranial nerves, resulting in total eye paralysis.
The margin between saving a patient's life and permanently disabling them is dictated entirely by how well the surgeon understands the pressure dynamics of that tiny room.
Wow.
And accepting the sphenoid pathology is resolved and the bleeding is controlled, the surgical team still has to get back out.
Okay.
And the primary exit route takes us right through the structural center of the face, which is the nasal septum.
The transeptal approach, which means moving instruments straight through the wall that divides your nostrils.
Exactly.
To do that, surgeons have to cut into and remove portions of the septal cartilage. This requires the exact same respect for load-bearing architecture that you would need when renovating a house.
It's a great comparison.
You can hollow out the living room to create open space, but if you knock out the central support pillars, the entire entire roof caves in.
And in the nose, those load-bearing pillars are called the dorsal and caudal struts.
Okay.
The biological architecture relies entirely on maintaining a strong, continuous L shape of cartilage along the bridge and down to the base of the nose.
So if a surgeon aggressively removes too much cartilage,
If they compromise those struts, the structural integrity of the face fails. The bridge of the nose caves inward, creating what's called a saddle nose deformity, or the very tip of the nose severely droops downward, known as nasal tip ptosis.
and leaving the struts intact is only half the battle, because the healing process itself can destroy the remaining architecture.
Right.
When you remove a square of cartilage from the septum, you leave behind an empty pocket between the two flaps of septal skin. Blood easily pools inside that empty space, creating a hematoma.
And a hematoma in the septum is uniquely dangerous because of how cartilage survives. Cartilage does not have its own internal network of blood vessels. It relies entirely on absorbing oxygen and nutrients from the mucosal skin that rests tightly against it.
Oh, I didn't know that.
Yeah, so when a pool of blood fills that empty pocket, it physically pushes the skin away from the remaining cartilage struts.
It cuts off the food supply.
Instantly, the cartilage begins to suffocate, and if that stagnant blood becomes infected and turns into an abscess, the cartilage will quite literally necrotize and melt away,
Melting away.
leading to the exact same structural collapse we just discussed.
So to prevent that melting, surgeons have to close the space, and they use a technique called quilting sutures.
Right.
They take a needle and sew back and forth right through the septum, squeezing those two flaps of skin tightly together. It's exactly like vacuum sealing a bag, sucking out all the empty air so no moisture can get in and spoil what's inside. It physically forces the skin back against the cartilage, eliminating any dead space where fluid could hide, ensuring the tissue heals flat and strong.
That's incredibly clever.
It is. So what does this all mean? We've traced a path from the millimeter-thin, tension-loaded skin between the eyes, drilled through the vascular bone of the forehead, navigated the floating arteries of the deep sphenoid, and rebuilt the structural pillars of the nose.
Well, if we connect this to the bigger picture, all of these severe complications, the mucoceles that emerge 7 years later, the crushed muscle patches, the blow-dryer burns, the suffocated cartilage, they prove a fundamental reality.
Which is?
The human head is a highly variable, deeply interconnected ecosystem. Intervening in one area requires a profound mechanical and biological respect for the entire surrounding neighborhood, because every tissue is programmed to react.
It is a neighborhood where every millimeter counts. And that brings up a final thought I want to leave you with.
Okay.
The source text repeatedly mentions that the dimensions of the frontal and sphenoid sinuses are highly variable. What that means is that your internal facial architecture is completely unique to
Not
you.
very true.
You have a one-of-a-kind fingerprint of hollow, pressurized spaces inside your skull right now. And it raises an incredible question. How might your own completely unseen, unique internal geometry be influencing how you experience everyday life?
Oh, that's interesting.
Does the specific hollow shape of your sphenoid cavity change the unique resonance and pitch of your own voice? Does the exact layout of your frontal bone dictate how quickly you recover from a simple head cold? Or why you feel barometric pressure changes differently than the person sitting next to you?
It's completely possible.
You'll probably never see the inside of your own skull. But every time you speak, or breathe, or step onto an airplane, you're experiencing the completely unique, invisible architecture of your own anatomy.